Assalamu alaikum. This is a case where it's a left-sided non-functioning kidney. You can see in the CT scan that it's such a huge kidney with a paper-thin cortex that it is occupying almost 1/4 or 1/3 of the left side of the abdomen, and the GFR was 0. So we place the working ports, and then it's a left-sided nephrectomy, so we will go for mobilization of the colon. Mobilization of the colon would comprise of mobilizing the spleen as well, because it's such a huge kidney. It is occupying all the left side of the abdomen, so we do not have space for dissection. It's really very difficult to perform the dissection. So we dissect from the crurum of the diaphragm, mobilize the colon medially, and here you can see that there's a huge pelvis of the kidney which is going too medially. So we realized that it will not be possible for us to dissect the pedicle really very easily in the presence of this hydronephrosis. And the more we dissect, the more we find that there is dilated renal pelvis. So we decide to go for aspiration, and we aspirated through the varus needle and suction, and we also compress the kidney from inside so that fluid goes out. Almost 1 liter of fluid was collected in the suction machine. Then here you can see that there's the ureter, and there is the left common iliac artery, and it's really, for the beginner, it's really difficult to differentiate between the two, and peristalsis is one way that the ureter can show itself. However, if you are not familiar with the anatomy, laparoscopic anatomy, you may take the iliac vessels, the common iliac or the external iliac for ureter. So really be careful. Here you can see that the difficulty can be seen even after decompressing the kidney. It's really difficult to maneuver around it. So we find the renal vein here, which is dissected from all around with the 10 millimeter right angle, but we are really finding it difficult to identify the renal artery. So we keep on dissecting, and we think that we have found the artery here, but we are not sure whether this is artery or this is a lymph node. The purpose of sharing this video will be clear soon. Here you can see that there is lymphatic tissue, inflammatory tissue, so we think that this is the artery. So we keep cleaning and dissecting with the suction, and after being a little sure, we started using ligashore. So this is here that it happened. So we cut the tissue without realizing that there might be renal artery or one of its branches. And the thing that we thought was renal artery, it turned out to be a lymph node. So we clipped that suspected artery. We found that the vein is not dilating. So we tried to apply the clip. But once we tried to apply the clip, you can see that the vein is distending. So we decide not to apply the clip and just remove it and try to find the artery, and here we can see that we have already injured and transected one of the branches of the artery, or it may be the main artery. So the trouble begins here, and then we try to find the stump of the renal artery, which may be originating from the aorta lower down, so that we can apply a clip to the common stump. So we take down the vein coming in the way, but we find that we have opened that ligated or transected artery. There was no other way, so we used our bipolar, the Escolab bipolar, and excellent instrument. Has been my friend since 8 years. So it stopped bleeding. But we know that this is just a temporary control. So we need to find the root of the artery where it can be clipped and we are able to sleep well at night, that we have clipped the artery. Otherwise, in this condition, it will really be difficult for us to have a restful night. So we complete the clipping of the already suspected area for the renal artery, and then we cut that and we find that there was an artery here. So it is good that at least one of the branches of the artery is clipped sufficiently. So that is, the transected vessel is not the main vessel, it is just another branch. So just to be cautious now, we are clipping every tissue that is coming in our way, and after doing that, we found that renal vein can be clipped and it is not distending. So that is because once we cut this vein, we'll be able to find if there is any stump of that artery. However, we decided to just go on with the dissection and mobilization of the kidney, mobilize the upper pole of the kidney, and then apply the clip to the ureter, and then transect it and remove the specimen from the bed. And then we clean the bed, and then we find that there is this artery. So instead of going for the stump, then we are able to apply at least one hemolog clip, and that's it. So it is secure now and we can complete the procedure. Thank you very much for watching.